Hi everyone, I'm Tony Rivera. I'm the Digital Marketing Supervisor for the Christopher Dana Reeve Foundation. I'd like to welcome you all to this month's online chat with Nurse Linda. Nurse Linda has been a leader and provider of rehabilitation nursing for over 30 years and a friend of the Christopher Dana Reeve Foundation for close to 20. As a moderator in our Ask a Nurse discussion, she focuses on contributing functional advice, providing the how-to on integrating various healthcare improvements into daily life, and answering your questions. Hello, Nurse Linda. Please take it away.
Hi, and thank you, Tony. And thank you, everyone, for joining us today on the webinar. Please feel free to write in any questions you may have in the question box, and we'll get to most of those as we go along in the course of the day. This past month, I've dedicated to bowel programs, which is a subject that I could go on and on about. In fact, people tease me about it. It's like, can you talk about anything else? Well, yeah, but I do enjoy the challenge of a good bowel program. Next month, we'll be talking about bladder programs. So just as kind of a heads up, you can look for information in the weekly blog, and next month we'll talk about bladder programs. But we get to start off with bowel programs today, which are wonderful processes that when they're working well, everything is going well and life is good, and then all of a sudden one day they don't work well, and it really kind of turns your life completely around and up on end. So there is a very actually humorous but a very truthful article that a gentleman had written quite a while back now, but it was about his experiences with his bowel program. And he did a lot with humor, kind of took a little bit of the edge off, but it was very well done because he really explained the whole notion of the bowel program and how, everything's just going along great with your bowel program, and you're thinking, oh, good, I've got this mastered. And you're moving along with it, and then all of a sudden one day something happens, and it becomes really difficult. So this is not unusual if you're thinking, oh, my bowel program, I'm really having a hard time getting it regulated, or I'm having a hard time getting adjusted to it. You're right in the crowd with everyone else. So sometimes it's when you're dealing with things like bowel program, it's not something that you're talking to a lot of people about. It's not something that you feel comfortable maybe in talking to someone who's not familiar with bowel programs or not dealing with all of those sort of issues. And it's certainly not something that you can really chat with your neighbor about it, especially if they don't have a spinal cord injury. If they do have a spinal cord injury, they'll be right there with you. They'll know exactly what you're talking about. First of all, there's a lot of difference in how people start their bowel programs. They're supposed to be started at the time of injury, or if you have illness and have paralysis from illness, sometimes they'll be started at the critical junction when your bowels aren't moving as you would like, or you're having some incontinencies or some impactions, and then with disease it kind of starts when it's needed to start. But with trauma, it's usually started right in the hospital. However, generally people are in the ICU, they're very sick, they're on IV fluids, and so they're not really taking anything in by mouth, and so sometimes they get started a little bit later. But that's when they should be started, is right away. They definitely are started in long-term care in the rehabilitation facility. Due to the way workflows are these days, sometimes they're started with people and they're just routinely done with people in their bed. And this is an unfortunate situation. It's just the way that healthcare has evolved with, cutting back and trying to save money. Sometimes we try to save money on different things that maybe if we put a little money into it up front, we'll save a lot more money down at the other end, but unfortunately a lot of people have their bowel programs start in the rehabilitation facility, but they started in bed, and so they never really learn that transition to sitting upright. When you sit upright to do your bowel program, you have a lot more effective function of the bowel program because you're relying on gravity to help bring the stool down and out. And actually, if you have a spinal cord injury or if you don't, gravity plays a big part in eliminating bowel elimination. So it's something to really consider if you do not have, if you're doing your bowel program in bed. If you're able to sit up, if you're able to sit up in a wheelchair, then you should be able to manage to sit up on a commode chair that's appropriate for you. Some people will be able to sit right on the toilet. Some people will need a commode chair for extra support for their upper body. So there are different types. You'll need to talk with your healthcare professional about what would be the right piece of equipment for you. Most generally speaking, payers will pay for some sort of commode chair. It might be a shower chair combination commode chair. You might be able to get the commode chair in the bathroom so that you'll be able to slide it over the toilet, which makes cleanup a breeze because everything just goes in the toilet. Or you might not be able to get in your home. The doorway might not be such that you could get into the bathroom, but you can still sit up in the commode chair, and there's usually a plastic pan or bucket that goes in the chair that can be just taken to the toilet. So it becomes much easier to do the bowel program when you're able to sit upright and rely on gravity. That's so often overlooked. Your bowel is going to move even if you're laying in bed. Usually people will lay on their left side because of the anatomy of the bowel. If you think about all those pictures you see of the bowel, there's the small intestines that fill up most of the abdomen, and then there's the large intestine that kind of curls around the outside perimeter of all those small intestines. And so the way that curls around is if you lay on your left side, it's going to be able to not have to force stool uphill to get out. It's going to go more downhill. But still sitting up is the best of all ways. So you want to start your bowel program with a good, healthy diet is one of the most important things. There's a lot of things that we overlook in our eating and ingestion that can affect the way that our bowels work. And again, this is for all people. So some people will eat some food that constipates them, and some people will eat some food that makes more of a runnier stool or more an immediate need to go to the bathroom. So whatever affected you before is probably going to affect you the same way after your spinal cord injury. So what you eat, it makes a big difference. If you have different diseases, so for instance, if you have developed diabetes type 2, which many people develop that years after a spinal cord injury, but because of lack of movement, sometimes people develop that. So sometimes people who have diabetes, if they have spinal cord injury or not, when they take in those carbohydrates, the minute that sugar hits the bowel activates and just completely dumps out. So there are little things that you need to know about yourself and your bowel program that will help you kind of control that situation. Certainly eating is the foods that you take in, and some foods that are taken in will give some people diarrhea and it will constipate other people. Cheese and bananas are two that I hear from patients, I had cheese and it gives me diarrhea, so I can't eat so much cheese. And then the next patient will come in and say, when I get a little bit of loose stool from my bowel program, I know I need to eat some cheese because that will constipate me. Bananas are the same way. Some people will tell me on one side of the coin and some people will say the other. So there's some foods that are kind of intermediary foods that we don't know how they're going to react in a person until, we see it happening. And so eating a healthy diet. Also, activity is another thing that helps our bowels move. So sometimes our bowels are working at all times. They do slow down at night, mostly because you're not taking in food. When you put food in your mouth, that stimulates your bowels to start working and moving. So it helps move the food along. It's called the gastrocolic reflex, which is a big fancy term for when you put food in your mouth, it stimulates your bowels to start becoming active. Now, they never really stop. They'll slow down at night because you're not getting that reflex action. But your bowels don't ever really stop, but they do become slower for long periods of not eating. That's why we always tell patients it's good to have a little something to eat about maybe 20 minutes before they start their bowel program, because that gets that gastrocolic reflex in action. It doesn't mean you have to sit down and have a 5-course meal. It doesn't mean you have to just stuff yourself to get this going. It can be a couple of saltines, or if you have something else that you particularly enjoy eating, warm fluids will help get that movement going as well. So we sometimes tell people to have a little cup of hot tea or something before their bowel program, because that tends to stimulate things along the way. Movement is another thing, and people say, but I have paralysis and I can't move. Even passive movement will help. So if you do some range of motion exercises, particularly in the legs, that will help stimulate movement in the abdomen. These things are also very beneficial. Sometimes people will do some of the more advanced therapies, which is very effective, but even passive range of motion can be effective. And even when you're doing your wheelchair push-ups, your skin releases, all of those kinds of activities of moving your lower body, even just tilting it from side to side, helps move some of the substance in the bowel back and forth. It will also help move gas along. Gas is a little harder to propel along because there's nothing really to grab onto by the bowel. The bowel is a gigantic muscle that just pushes the substance in the bowel along. It usually works in one direction from top to bottom. So anything you take in follows along, goes through the stomach, drops down through the bowel, and then out the other end. Now, sometimes people become sick, or maybe they get an impaction. Something happens to their bowel, and it gets stopped up for some particular reason. The bowel does have a little safety device in that things can go the opposite direction. You don't really want that to happen. But when people vomit or they throw up, there's something wrong in the digestive tract that the body's trying to get rid of that. So if you have the flu, you might have some kind of germ in your stomach or in your bowel, and your body just wants to get rid of it right now, and whoosh, you throw up to expel that, or you have diarrhea to get rid of that, whatever that noxious substance is within your bowel. If you do get an impaction and gas, air, other stool cannot pass through your bowel, things will eventually start to back up. You kind of get a sick stomach. You might have a taste of, a bad taste of something in your mouth, or you might find that you're throwing up, and when you look, you can see little flecks of stool in there that's coming from your intestines. Sometimes their breath will just smell like stool, and so you know that there's a blockage in there. So you need to have that immediately checked out so that can be released. So sometimes people get impactions, they're not taking in enough fluid, or their bowels moving particularly slow. The bowel, as I said, it's always working, and so it's always extracting nutrients from the food substances going through the bowel. It is always extracting fluid as well from the bowel. So what you take in and you chew up in your mouth, it goes down the esophagus into the stomach. The stomach digestive enzymes start working on breaking that food down. The saliva in your mouth is also breaking that food down, but it's swallowed. It goes down into the stomach. It has some more, the digestion that's going on there is that gastric juice is being squirted out of the lining of the stomach, and it's breaking down that food. It will then go out the other end of the stomach, and it goes into what's called the duodenum, which is the first part of the bowel. And that's where you get bile added from the gallbladder, and food gets either further digested. So by the time it gets to the actual small intestines, it's what's called slime. It looks like slime. It's called chyme, CHYME. But it looks like slime. It looks like green slime. It's kind of a green, thick sludge. It's green because that's the color of bile from the gallbladder. And so that passes all through the small bowel, and all these nutrients and fluids being extracted from it. So it starts to get a little more solid and a little more formation. By the time it gets to the large intestine, it's starting to really look more like stool. And then by the time it goes through the whole large intestine, a lot of that, the last of the nutrients and the fluid is extracted from that chyme. And then it's stored in the rectum until it's time for you to remove it. So that's where we do the bowel program. Now, in the bowel program, generally what happens is people usually have a process. So if you have an upper motor neuron injury, which is a cervical injury or a thoracic injury, generally speaking, the bowel becomes very reflexic. So when there's stool in there, it will automatically be evacuated. Now, it will take a little bit of it to collect in there in the rectum. That's the storage unit. And so it takes a little bit of stool to be collected, but that's automatically expelled, which is why you do the bowel program. To get the activity in the lower bowel, to get that expelled, people usually start out with a suppository, and it has to be placed in the bowel up against the wall of the bowel for the body heat to melt the coating of the suppository. And then the suppository, the substance in the suppository that actually makes the bowel move has to be up against the bowel to start that action. Some people are very anxious to do their bowel program, and they just put the suppository in straight up, and it goes in the middle and the center of the stool that's collected there, and so that's not warm enough for it to melt, and it's not up against the bowel, so it won't stimulate that action. So it's kind of like, well, yeah, you put the suppository in, but you're not going to have any action from that. Now, if you have a lower motor neuron bowel, that's the kind of bowel that we call flaccid, and it just will collect stool and collect stool and collect stool in the rectum, but it won't be evacuated. And so for those individuals, those are the bowel that doesn't really respond to the suppository. So you just start with digital stimulation, and that will help evacuate the bowel. So those are the two routines that are used. So either you use a suppository or you just start in with the digital stimulation. If you use the suppository, you should wait about 10 or 15 minutes, maybe even less. I should say 5 to 10 minutes, and then do digital stim. Now that's an insertion of the finger, and it should be gloved, and it should be very well lubricated. Sometimes that lubrication, you put it on your gloved finger and it just plops right off. So you want to be sure that you've got that finger well lubricated, and you push that in the rectum and do a circular motion. There's an internal sphincter and an external sphincter. So you want to relax both of those. Now again, some people are very anxious to kind of do their bowel program, get it going, get it over with. And so they put their finger in and they do some wild gyrations with that, which, as you know, whenever you overstimulate something, if you have spasticity, that tends to increase the spasticity. So a slow, even, gentle swirling of the finger will help very much in actually making your bowel program work faster, because you're relaxing both of those sphincters instead of tensing them up. So the more you hurry through that bowel program, the more time it's going to take to really do an effective bowel program. you might need to do the digital stimulation a couple of times, make sure your bowel is empty, and then you can go on. So as I say, for individuals, the bowel program works great until it doesn't. And sometimes what happens is you could be doing an effective bowel program for years, and all of a sudden it's not working. And so why is that? You can look at your diet. You can look if you've changed your exercise regimen, or it could just be the fact that you've gotten older, and so your bowels slow down, because everybody's bowel tends to slow down as we age. And so sometimes you might need to add something different. If the stool is very dry when it comes out, you want to add moisture, so maybe drink a little more fluid. That doesn't mean to sit down and drink a whole glass of water just all at once, but just add a little more fluid, maybe just a couple of swallows at first. You don't want to overload your system with fluid. So just add a couple of swallows at meals, maybe a half a cup of fluid at meals. And then you can eventually, over a few weeks, increase that. So the idea is to go really slowly with these. If the stool is particularly dry, you might want to add a fiber or a bulk laxative to that stool. If the stool is particularly soft, you might want to look at reducing any kind of medication you might be taking for in stool softening medication. Here again, that fiber is important. If the stool is too soft, you can add some fiber to bulk it up. So fiber kind of works in both ways. So if there's any question about the bowel program, we'll be sure and answer those. Just be sure to write those right in the question box. And you can also refer to this month's blog for a lot more detailed information about the bowel program. One last thing to say about the bowel program is that our emotional state can really affect bowels. So people with or without spinal cord injury will comment about how I was really nervous. I had a job interview, or I'm expecting a phone call and I'm really nervous about it. And so they say, I had to go to the bathroom because I suddenly got this urge. So sometimes our emotional status can affect our bowels, even with a spinal cord injury, and sometimes all of that physiological responses to tense situations or even happy, great situations can kind of make our bowels a little more active. So sometimes that's, it's a one-time situation and you have some problems with that, but it's just something to know if you are the kind of person whose bowels get in an uproar. A lot of people will say, my bowels get in an uproar because of some situation. You can kind of plan for that and know what to do about that as you go along. So we do have some questions in the question box. So let's just start working through some of these questions, and I hope that they'll answer provide some information for everyone. So the first question is, what are some common treatments for lymphedema and spinal cord injury? So lymphedema is edema or swelling of the lymph glands, the lymph nodes. And sometimes people in their extremities will get some edema in their extremities, and so this doesn't pertain to bowels, but it's just like what happens when you get that swelling and what can you do about it. So it's not that uncommon to have swelling when you have spinal cord injury, because the way our body eliminates fluid from our body is that the heart circulates and pumps the blood through the body, but one of the helpers that we have to help the heart move that fluid along is when we use our muscles and to move our extremities, and that helps provide some pumping action that will help bring that fluid from the feet up or from the hands up to the kidneys to eliminate that. So again, exercise is always an important thing. Another thing that you can do is to wear your elastic stockings and look at your stockings. If you've had them for a couple of years, make sure that the elastic is still tense in them. Sometimes we have people that go back to wearing elastic stockings for one reason or another, and it's usually some sort of edema problem. And what they'll do is they'll get out their old TED hose or their anti-embolum stockings, and they'll put them on, but the elastic is kind of eroded. It's, if you think about underwear, if you have underwear for too long, the elastic just kind of wears out. So elastic doesn't last for very long time. So look at your elastic stockings and make sure that they still have that elasticity to them. If not, you might want to buy some new ones at the drugstore or medical supply store. You might be able to get them funded by your payer if you're having some edema problems. The other thing is to look at your positioning. So a lot of people who use chairs find it very casual to sit with their legs crossed. They feel like this looks like other people, and it provides kind of a casual look. If you're a lady wearing a skirt, sometimes people like to have their legs crossed. This is a problem for people with edema because the pressure of one leg over another leg, even at the ankle or at the knee, cuts the ability of that circulation to pump that fluid back up. Another situation is if you have your feet dependent, your arms dependent, or if you hook your arm over the back of the wheelchair, again, you're cutting off some of the vessels that are bringing that blood supply back. And so look at how you're positioning yourself. Another thing is to think about having your extremities elevated to make sure that the fluid is working, again, with gravity. Gravity is so much our friend. And so elevating your legs and your arms whenever you can is important as well. Now, I see we have a hand raised. So, David, if you want to type in your question, I'll be able to see it. So I just want to be sure and tell that to David, who has his hand raised. And I'll be looking for that. Let's see. So I hope that answers the question about lymphedema. What type of doctor can you consult with about bowel management? Pretty much anybody should be able, any kind of physician or nurse should be able to help you with your bowel program. Now, there are people that have a lot more experience with this. So if you go to your general practitioner, they might actually not have anybody in their practice who's working with a bowel program. Or they might have people who have constipation. Sometimes people in the community, sometimes health professionals say, oh, you're not having a bowel movement because you're constipated. And that can be true for the general population. But for people with spinal cord injury, the reason why they're not having bowel movements and why they need help and assistance with their bowel program is not because they are necessarily constipated. Of course, you can become constipated, but that's not generally the basic problem with the mechanics. The problem is the neurogenic bowel. So there's some nerve problem that's not being conducted to the bowels. Now, your bowel will work through the autonomic nervous system. So it will always be working, but sometimes it's not working as strongly as it needs to be. And the big problem, of course, is the control of when you want to evacuate your bowels. So nobody wants to evacuate their bowels in the middle of a movie or dinner or any kind of social or work engagement, or if you're a person going to school. Nobody wants to have a bowel accident at, really any point in time. You want to have control over that. And the way you get that control over that is to do a bowel program to make sure your bowel is empty. If you are having a problem with diarrhea, there are things that you can do. You can, of course, always take an anti-diarrheal medication. You want to be careful with how much of that you take because, anything that you try to control your bowels with that you take by mouth is going to take a long time to show up in your bowel. So performing an effective bowel program is really about the best situation. If you have a spinal cord injury specialist, doctor, or nurse, they will be able to be the best ones to help you with your bowel program because they've seen it all. And so they'll be able to really direct you with your individual situation. Now, a lot of people will think, okay, I need to do something about my bowels, so I'm going to take this pill or I'm going to do this treatment, something. They'll think and they'll say, okay, so the bowels work. I put food in my mouth this morning. I should see some results within 24 hours. That is not necessarily going to be true for people with spinal cord injury. It might take quite a bit longer for food to be processed. And then again, depending on what's going on with your own personal health issues is going to make a huge difference about how well your bowel functions. So if you have other diseases like diabetes, what kind of food you eat is going to affect that. People who have long-term diabetes, whether they have a spinal cord injury or not, are going to have problems with their bowels, with constipation, not being able to evacuate, or eating a carbohydrate or a sugar, and all of a sudden, boom, their bowel just empties right then and there. So you want something a little more predictable, and so working with somebody and then thinking about it over the long term. So if you add something like fiber to your diet, if you decide to take a fiber wafer, be sure and read the package instructions when you're taking a fiber, because it will tell you to drink so much water with that particular product. If you don't drink enough water, that fiber becomes like a rock in your bowel and becomes an obstacle rather than a helper. So be sure and read the product and know how much water you should be drinking with that. And then don't expect to see real results from that for a week or two. So it takes a long time, a lot of trial and error for people to get their bowel program managed. So don't be anxious, but a good spinal cord doctor, any rehab doctor, if you don't have a spinal cord specialist, but you have a physiatrist, which is a rehab specialist or nurse, those people are probably going to be the best people to give you information. There's a question here about somebody in the last 3 years, they've had issues staying up in their chair. Even though they're doing pressure releases, they're getting some stinging, burning pain in the lower half of their body. So this can often be a problem because of neurological changes. So it could be neuropathic pain. Now, the good news is when you start feeling something in the part of your body where you didn't feel before, that means that the nerves are trying to make some kind of effort to communicate with your brain. So it's kind of a good news, bad news story. It's great that that's happening. On the other side of the coin is when you have pain, nobody really wants that. We want to get pain taken away from us. So we want to be very cautious about that. But you could try some different techniques about looking at maybe some medication for pain, or doing some different techniques to help, some non-pharmacological techniques like some imagery, or using some kind of biofeedback to help control the pain and getting that. So this person's doing the pressure relief, which is important to change your position, because if you don't have a spinal cord injury and you sit too long, you get all cramped up. So if you're sitting with a spinal cord injury, your body is still feeling that. It's just not telling your brain that you're feeling that. Another thing to do would be to look at your seating system. If you've had that for a while, she's had a spinal cord injury for the last 3 years. She's been having problems with this. Maybe your cushion is worn out. They do wear out after a certain amount of time. Or your body changes. In 3 years, your body could have some changes as far as your positioning needs. So maybe you need to have a different support system for your feet, or maybe a different back to your chair. So talk with your person who's prescribing your wheelchair for you, and see, they usually have some different models that you could try out, and see if there's something that maybe is a functional problem that will address that pain for you. So all important things to do. The next question is taking a fiber additive such as Metamucil okay for someone with a spinal cord injury? Why, that is what most people do take. Now, Metamucil, Citracil, there are a few others. They're called bulk laxatives. So you can even get generic bulk laxatives. It is unfortunate, the choice of names. The reason why they're called bulk laxatives is they're adding fiber to your stool, and if you add fiber to your stool, it makes your bowels move a little bit easier. It's easier to move bulky stool than it is to move loose stool or really rock-solid stool. So they are laxatives in the fact that they do make stool move through your bowel faster. They're not the kind of laxatives that we tell people to avoid because they're so unpredictable. Metamucil and these other bulk-forming laxatives, I just wish they were called bulk formers and forget the laxative part. But any of those will help add some fiber to that stool and help move it along. Before you take any kind of medication, either prescribed or over the counter, you do want to check with your physician or your healthcare provider to make sure that it's okay for you to take that. So if you have an obstruction, you wouldn't want to begin a bulk former because that's just going to pile more on the other end of that obstruction in the bowel. So you always want to check no matter what to see if there's any interaction with other medications that you might be taking. It's pretty hard to find an interaction with Metamucil or the bulk formers, but still check. You also might want to check with any medication that you might add, even if it's over-the-counter medications, to make sure that it's not that there's not a food restriction. I don't know of one with Metamucil, but just be sure and check to make sure it's okay for you. Everybody's a little different. You might have something in your health history that might make a problem for you. If you have a colostomy or something, just be sure and check that for you as an individual, it's an okay thing to do. One thing about the bulk formers that I did want to say is that, again, you need to check the instructions very carefully and make sure that you're taking them correctly, because if you don't take enough water with these, they do cause more trouble, and so that can really be a problem. Now, the bulk laxatives come in all kinds of flavors. They have some new flavors. They used to come just in the orange flavor, but now they come in an apple flavor, and they have different tastes to them. They come in powders. They come in that are mixed with a glass of water. They come with a powder that can be mixed with a glass of water that does not have any of that grit or taste. It's just like drinking a glass of water once you put the bulk fiber in there. They can be in cookies. They can be in wafers. So they come in a variety of ways. Now be careful and be sure and check the package to make sure that you're getting a product that is sugar-free. A lot of times, as I said, diabetes is a higher incidence in people with spinal cord injury. So you'll want to be sure and get a bulk former that is not adding extra sugar to your diet. Sometimes people, again, this is where you want to check with your physician or your healthcare provider. Sometimes people will start taking Metamucil and they'll just start taking it on their own because it's over the counter and they think, well, it's got to be safe, right? But sometimes not for everyone is it safe. So sometimes people will start taking Metamucil. These bulk formers are loaded with sugar unless they're processed particularly, and it says sugar-free. Now, the sugar-free variety is going to be more expensive, as is any product. When something is omitted, the price seems to go up. So if you are diabetic, you will want to be sure and look at that product and make sure you're getting the sugar-free kind, because your blood sugars are going to go all crazy with that Metamucil that has the sugar in it. And it could be Citracil. All of them have sugar and sugar-free varieties. So make sure you get the sugar-free kind just to help lower your risk of diabetes. So pressure sores on the skin after 20-plus years in wheelchairs. We have a person who's 52, and they had the first serious pressure sore in 21 years. Oh, how disappointing that must have been for you to go all those years and not really have any problems, and then all of a sudden you do. So what can you do to minimize the risk after years of no problem? So this is one of those siren songs. We get kind of lulled into this complacency because after 21 years, why would you ever think, you're doing everything right? This is one of those like, oh my gosh, how could this have happened? And yet it does. And the reason why it does, probably more often than not, is because 20 years later, you're 20 years older. Our skin is a wonderful, resilient organ to the body. It covers the whole entire outer surface of the body. It's our first defense. It keeps anything out of the interior of our body. And so it's a wonderful thing. But as we age, the skin becomes less elastic. And so what you really need is that elasticity to your skin to help resist those pressure sores. Also, as we age, our muscles become a little bit thinner, and this is for everyone, whether you have a spinal cord injury or not. It's just the fact of your prize for getting older. Things just aren't quite like they were when they were brand new. So what usually happens to people in their later years is they end up with their skin quite not so elastic, which you don't even notice because it's not like one day it's not elastic. This has come over a period of 20 years. They're probably doing their pressure release exercises, they're monitoring their skins, and boom, here's this pressure sore. Oh my gosh. I'm sure you were devastated. So what can you do to help minimize that? Keep up with the pressure release exercises. You might even want to add more. Do them more frequently. We usually say every 15 minutes. If you can do them every 10 minutes, it seems like, when you have to do them and you're doing them that frequently, it seems like that's all you're doing. But if there's some way that you can build that into your day. Another thing is to, again, look at your equipment. You might have a cushion that maybe you've had for 10 years, and maybe it's not doing the job that it used to be doing. If you can add any exercise, even passive exercise, range of motion to your extremities, that will certainly help keep those muscles a little bit more built up and stronger. Pressure sores come from within the body. It's where the bone presses on the muscles wherever there's pressure. So when you're seated, you can get pressure ulcers on either side of your bottom. You can get pressure ulcers on the sacrum. You can get pressure ulcers on the elbow. Wherever there's a bony prominence is what they call. So if you feel the end of a bone, you can get a pressure injury there. Some people I have seen will get pressure injuries along their vertebrae, where every single vertebrae, kind of pokes out from the back of the spine, and you'll just see it dotted all the way down the spine. So basically what you need to do is keep up with the pressure releases. Check your equipment to make sure that you have equipment that is working, because when you're younger, and I see this so often when I see the younger adults come in with injuries, and I ask them about their pressure releases. Well, I don't really do them so much, is the answer that they get. Their skin is young and healthy. They still have good muscle tone, and they probably don't need to do them as much. But it's a good habit to get into, because you don't know when that critical point is going to happen, when the pressure sore is going to occur. It actually only takes a matter of seconds to have that bone sticking on that muscle and to have circulation cut off to that area. It does not, they say, oh, well, you can turn every 2 hours. Well, it's really a lot quicker than that people have trouble. So be sure and check your equipment. Make sure you have good equipment on your chair. Make sure you have good equipment in your bed. If you transfer to another seating arrangement, be sure and take your equipment with you. So like if you're going on an airplane, they have very cushy seats on airplanes, but they're not pressure reducing cushions. It's more like sitting on a pillow where the pillow foam just contracts down, but there's not that pressure dispersion. So be sure and take your equipment if you're going to sit in a different chair. If you go to work and you sit in a different kind of chair, or you're going out to dinner and you want to transfer into the chair at the restaurant or something, be sure and take your cushion so that you're never without that. So good luck on that situation. I hope that you're getting some good care for the pressure sore. I hope that you're staying off that area. Some people say, well, I want to, I will just sit on it for a few minutes, and that few minutes is just undoing all the hard work you did for staying off of it. That's really the only way to cure a pressure sore, is to get it to close up. After you have closed that, that tissue is now scarred, so it will not be as elastic as the rest of your skin. So you'll want to be sure and maybe up your pressure dispersing cushion that you're sitting on. So very important. If it's a serious pressure ulcer, it's got a lot of exudate, you might want to talk to somebody about wound vac. Those are being used a lot for pressure injury. It may or may not be the right thing for your particular situation. I just offer it as another option, which might be helpful. Sometimes people have to have surgery to close the pressure area, in which case part of the muscle and the skin tissue is moved over that area. But after surgery, there's always a scar. So you have to be very careful with that scar, because they are not elastic as your skin is. So good luck on that. And we're going to be hoping for a positive outcome there. We have another question here about getting Botox in the bladder every 6 to 9 months, but it only seems to last 1 to 2 months, and then they have UTI symptoms till the next Botox. So all urine tests are coming back negative. Any surgeries or devices I could use instead of Botox? Well, if you're getting those injections every 6 to 9 months, but that only seems to last 1 or 2 months, you might want to talk to your doctor about having either more Botox injected when you're having the injections, or having more frequent times between injections. So it should align that by the time the Botox wears off, that it should be time. You shouldn't really have this problem so quickly after having that Botox. Now, sometimes it says they have UTI symptoms, but the tests are negative. There are sometimes when your urine tests come back negative, but there still be a little bacteria in there. So, you might want to talk with your healthcare professional about the results of these urine tests. It's probably not the situation here, but I bring it up just so you know you can cover all bases. The other thing to look at is if you want to do something different besides the surgery, or besides the Botox. If you're finding that that's not working well, you might want to look at if the feeling of these UTIs is some kind of neuropathic, I will call it pain, but it's not like so painful, but it's an irritant. Sometimes neuropathic pain is more like an irritant. When we talk about neuropathic pain and people who have it, it is a dramatic thing, and people know it, and it's very frustrating and uncomfortable. But sometimes neuropathic pain is just like a little tickle that just won't go away, and that can be pretty irritating as well. So I'm wondering if it's not the Botox that's wearing off, but it's some other kind of physiological process like a neuropathic pain or tickle that is being sensed. So that would be another avenue to test, to ask your healthcare professional about. And then the other thing, any surgeries or devices that you could use instead of Botox, Some people, instead of catheterizing, have found, especially women, have found success with the mitral fan-off procedure, where actually the appendix is rerouted and attached to the end of the belly button on one end and attached to the bladder on the other. Now, most of the time women have this surgery because the anatomy is so difficult to get when you're out in public restroom, or if you're in different places, it's so difficult to catheterize. For men, the anatomy is more available, and so men don't have it as often, but that might be something. I don't know if that will make any difference in your symptoms, but again, another avenue to think about. But I would first ask about the timing of the Botox and the dosage, and then I would ask about that neurological, if there's any neurogenic pain or any tickling going on, something that maybe you just need a little something to take the edge off if your UTIs or if the urine tests are truly negative. And then the other thing to think about is if you want to have something like that, you would have to talk to your surgeon and your urologist to see if they think that would even, if they did the mitral fan-off, if that would even do any kind of help for your particular case, because they're usually not connected in the same way. But since you ask about surgeries, that is one that a lot of people are having for a variety of reasons. Okay, so the next one is, what do you do when a patient has very high blood pressure and is in bed, besides checking catheters and wrinkles in bed and lying flat? Well, if a person has sudden onset of high blood pressure, so if they're having autonomic dysreflexia, you have something built into your body after spinal cord injury that can help you, and that is to sit upright as quickly as possible. So if you find that nothing, you think maybe autonomic dysreflexia is happening, that sudden increase in blood pressure, it's most often caused from a blocked or kinked catheter. It can be caused from wrinkles in the bed. It can be caused from clothes that are too tight, skinny jeans, belts that are too tight, tying shoes too tight. But you do have the option of, instead of laying flat, you want to sit the person up right away, because after spinal cord injury, people have a harder time regulating their blood pressure when they go from laying to sitting. And so when this happens, you can take advantage of that orthostatic hypotension by raising their head up very, very quickly, and that will bring down their blood pressure. Now, if this is an ongoing problem and they have very, very high blood pressure, you'll be sure and check with your physician, or maybe even call 911 depending on how high that blood pressure is, so that you can get medical treatment for that. You would want to be worked up to see if you have autonomic dysreflexia, and then know the other things that can cause that is if you have a full bowel, or you have a bowel impaction, or sometimes people get autonomic dysreflexia just from the irritation of normal household breezes blowing across the skin and irritating the fine hairs on the arms and legs. So it's a very serious situation. There is a wallet card that the Christopher Dana Reeve Foundation has. So if you're not sure about autonomic dysreflexia, you can obtain that wallet card. You can take it to your healthcare provider and say, I think I have some of these symptoms, and then they can help you get proper treatment for that. But it is not something that you want to just let go. Having high blood pressure or blood pressure that's up and down quite quickly and rebounding can lead to other serious medical problems. So you do want to have that checked out. Here's a person who's writing in that their son has a C5 incomplete injury and has been having increased shaking or tremors in his legs. Any suggestions on how to alleviate this? So 2007 is when this injury occurred. So we're talking about really 11 years, 10 to 11 years. So what happens with spasticity is that is one of those things that does not come on quickly. When you're in the rehab hospital, your body is still in spinal shock from that injury. And so what happens is that spasticity might not develop until like 2 or 3 or more years later. And so people are kind of presented by this when they're out in their home, they're more on their own. And so it becomes really a problem taking care of it because they've not been with health professionals when it started. So there are medications that can help relax those nerves that are causing those tremors. Something that people often overlook, and I sound like a broken record, but people often overlook doing range of motion exercises that will wear out those muscles, so it makes them so they don't have the energy to do that severe shaking and tremoring. There's also the way the muscles work is there's 2 sets of muscles for every activity. So there's a push muscle and a pull muscle, and one's usually in the front of the leg, one's in the back of the leg. Same thing in the arm, one's in the front, one's in the back. So if you have somebody who is having those tremors, if you can overstretch the muscles that are causing these tremors, you can do what we call break the tremor, so it will stop. So if the tremor's in the leg, if you pull the foot up so the toes are coming up towards the nose, and if you push the leg down by the knee, you can break that tremor and overstretch the muscles to get that to stop. Now, it'll only stop for so long. Some people have these tremors and they just, okay, it's not bothering me, so fine. Some people have the tremors that are so disruptive to their life, or they don't want to be out in public and have a tremor, so they'll get medication treatment for these. You can take medication by mouth to help calm the tremors. That will calm every muscle in the whole body. So sometimes people have fatigue because they're taking muscle relaxants to calm these tremors. Sometimes people will have Botox injections into the muscles that are doing the tremoring so that they'll stop for a period of time until the Botox wears off and then they have it again. Now, for a while, Botox was not authorized as a treatment for spasticity, but it is now. And so if you go to somebody who has the correct wording and is able to get that authorization, insurance will cover that. We have one more question about a person who's having have their right arm paralyzed with limited sensation below the forearms and chronic pain. Phantom pain. It's been 40 years of living in pain. Oh my goodness. So why is it so hard? Well, that's neurogenic pain. Phantom pain is neurogenic pain. And so you, again, you would want to look at, this is the more severe end of that. Like I was talking with a person who had the bladder kind of tickling kind of pain. This is more the severe kind of pain. So there are pain specialists that can help you with this. Physiatry people can help you with this. There's medication, but again, to take that amount of medication to control this extensive pain would be a lot of medication to take by mouth. So you could try if you had it. If you have neurogenic pain in the lower half of your body, sometimes people will get what they call a baclofen pump implanted. Since this is just in one arm, that's not going to be the effective answer for you. But you might be able to try some injections of different treatments. There are different nerve blocks that can be done in particular for phantom pain. Now, the kind of doctor that you would need to get to do this would either be an orthopedic specialist that's a specialist in hand and arm injuries, or surprisingly, a plastic surgeon who is a specialist in hand problems. Both orthopedics and plastic surgeries do these kind of special nerve blocks in the upper arm that should be able to help you relieve of your pain. So you might want to look in your health plan and see if you have that available to you. You might have to travel to find a person who is adept at doing all these kinds of nerve blocks. But there are nerve blocks that can be done to do that, and so I imagine you just haven't hit quite on the right physician. A lot of times medications can be used, but it's very much a trial and error process because all of us are different from each other, and then the type of injury and how the pain began, and the issues of your extremity and what's gone on, the changes that's happened in that extremity over the 40 years. So these are all things that you might, so it makes treatment a little bit different. The other thing that you might want to think about when you talk to the orthopedic surgeon or the plastic surgeon is to look for carpal tunnel entrapment there at the wrist, and also what they call cubital tunnel, which is entrapment of the nerves at the elbow. And sometimes there's surgery that can be done to release those entrapments. You can even get entrapments up at the shoulder that you might not know the injury is at the shoulder because it's manifesting at the hand. So be sure and have electrodiagnostic studies to see where that is, but you'll be guided by that particular physician. And unfortunately, we are at the top of the hour. So at this point, I was trying to look to see if David's question was on here real quick. We have so many questions that we didn't get to. Oh, yes. Here's David. He had his hand up, so I don't want to leave without answering his question. So he uses suppositories every other day, and last night he had a low output. Would it make sense adding another suppository or sticking to schedule? David, always sticking to the schedule is a good thing. Sometimes a low output is not unusual. Maybe you didn't eat that much. Maybe your bowel slowed down for some particular reason that day. So keeping to schedule as long as you're not having any accidents in between. If you find you did not have a good output and you want to try your bowel program again the next day instead of going every other day, that's fine as well. But the idea of doing a bowel program is to train your bowel so that eventually you won't have to use the suppository, but the stool will be there and you'll be able to manually evacuate that. And so the bowel gets actually trained that this is the time when I'm going to empty. And so that's when you get very safe with your bowel program. So stick to your schedule as best as you can. If you decide that you would really like to do another bowel program again tonight, you can also do a digital stim and see if there's any stool in the rectum. If there's not, you don't need to do it until the next scheduled time. So I hope that answered your question. And so we are finished with our time today. Please, if you have any questions, or if I didn't get to your question, I'll be on again next month. But if you would like, you certainly can write into the blog or just post a question on the blog, and I'll be happy to answer your question. You could copy-paste your question and put it right on there. So I'll be happy to talk to you at any time on the blog, and we'll see you next month. So I'll turn it back to Tony.
Thank you so much, Nurse Linda, for today's webinar. It was very, very informative. But thank you for everyone for joining us today. This presentation was recorded and will be archived by the end of the week for viewing at our YouTube channel. Thank you again, and thank you so much, Nurse Linda.
Thank you. Bye-bye.